Good morning to everyone.
Mehta sir, we are good to start. With your approval, we will commence the meeting, sir.
Please, I think we are on time now. We should start.
Yes, sir. Revered chairperson of this webinar, Dr. A.B. Mehta, esteemed moderators, speakers of the webinar, distinguished doctors, technologists attending this meeting, our channel partners, my colleagues, and everyone, a very good morning to one and all. I am Ravi Patnaik and I am your host. I take the proud privilege of welcoming you all to this academic feast that is scheduled for the next 90 minutes, packed with a lot of scientific content and stalwarts from their respective domains speaking on various topics. I'm sure you will find this webinar quite informative. This is go
ahead.
Yes, sir. So this is today's the invite that has been circulated, and this is the agenda that is put on the screen. So, sir, we have Dr. V.S. Ramchandra, who is Director Cardiology from Sri Sri Holistic Group of Hospitals, Hyderabad. Dr. Ajay Kumar Umakant Mahajan, who is Professor Cardiology and Interventional Cardiologist from Lokmanya Tilak Municipal Medical College Hospital, Mumbai. Dr. Sanjay Bhatt, Senior Interventional Cardiologist from Aster CMI Hospitals, Bengaluru, as the moderators of the session. And we have Dr. Gopalakrishna Gokhale from Hyderabad, Dr. Katharina Kiss from Vienna, Dr. Anoop Agarwal, Dr. Maulik Parekh from Mumbai, and Dr. Lluis Asmarats from Barcelona, Spain, who would be speaking on various topics today. And Dr. A.B. Mehta, Director of Cardiology from Jesloke Hospital and Research Center, Mumbai, India, would be chairing today's program. Now, I deem it my proud prerogative to introduce Dr. A.B. Mehta, sir, who is the chairperson of today's webinar. Dr. Ashwin B. Mehta, who is popularly known as Dr. A.B. Mehta, has been good at academics since inception. He secured first class with distinction in MBBS and MD examination in various subjects, securing 19 gold medals at the University of Mumbai, holding record in 108 years of university in medicine. Dr. Mehta has many achievements in his stellar career that spans more than 5 decades. Each of these have been milestones in the annals of cardiology in India. Dr. Mehta has been the first one to deploy drug-eluting stent in India on 7th May 2002. Dr. Mehta has more than 700 publications and presentations in various national and international meetings. Towards his contributions to the development of cardiology and a scintillating career in which he has served many patients, the Government of India has awarded him the highest civilian award, Padma Shri, in the year 2004. Dr. Mehta has participated in live demo workshops in complex interventions across the globe: India, China, Japan, Singapore, France, Sri Lanka are a few to name. Sir, I once again take the pleasure of welcoming you to this webinar, and I request you to take the proceedings of the webinar, sir.
Thank you very much, Ravi, and my friends. I have to make 2 declarations. Number one, that I think, how did I earn the position of chairmanship for this particular seminar, in which I am surrounded by the luminaries who has much larger experience than I have? Probably it is a goodwill that has worked on it. The second thing is about story on my 19 gold medals. It becomes so widespread that it attracted an income tax raid if I have declared the gold or not. And that created a lot of trouble. So now onwards, I do not wish that people should talk about my gold medals. I'm so happy to meet few people, and especially Dr. Katharina, who has done really a pioneering work in the tricuspid valve treatment. You know, when the science grows beyond the human capacity, it emerges out as a specialty, and the people decide to focus on particular aspect of that part of the science. And that is how the specialties emerge And today, I would say that structural heart disease on its own has been a specialty which I think is growing by leaps and bounds. And, the structural alterations could be congenital or acquired, and we are not going to discuss today about congenital one, but we are going to acquire the functional disorders. This has happened due to a disease which is something else, but secondary to the disease, when the structural changes take place, they simply aggravate disease, and this is a vicious cycle. And I think, therefore, the treatment of the structural disease, although in vast majority of the cases is palliative, has helped a lot to improve the patient's quality of life, reduces frequent hospitalizations, in many cases, even the survival. So with this, I think I may say one single example. When Alain Cribier was allowed to do the aortic valve in a human being, the first patient that was given to him has a survival rate of only 24 hours. And you can imagine the kind of stress, the pain, difficulties that he must have undergone. And today, I'm proud to say that with the improvement in the life expectancy, now that the people's average age is 83 years or more, and now by the year 2026, 130,000 aortic valve will be replaced transcatheter in United States alone. So I think this is going to work in a positive direction in this way that will help and enable the patient to live the normal, healthy life. And of course, the life expectancy is a totally different issue, but the quality of life will be remarkably changed. Tricuspid valve, although I don't have a big experience, but I realize that it's so rewarding. A case of mine who had a tricuspid regurgitation with impending cardiac cirrhosis, and when he received TricValve, such change happened in his quality of life that what he ever not thought of doing, he's been able to do. Kind of physical activity, kind of creativity, kind of time spending with the family completely changed. And I think there are many ways of treating tricuspid valve. I had one more case, and that was an Epstein's anomaly, which was operated with a bioprosthesis in tricuspid position. Was not doing well due to degeneration of the valve, and we gave another valve. And I think she did also remarkably well. She's been traveling all around the country, and she's finding herself having a different quality of life. Well, I can go on and on, but I think this is the time when I should. So I think the structural heart disease is a very, very important and emerged new branch of cardiology. And I think this particular debate, this particular conversation, as they call it, organized by Relisys, is going to go a long way in our knowledge, in our method of practice, in our understanding, in our applicability of our art to our patients. With this remark, may I go back to Ravi and please invite the first speaker.
Yeah, sir, it would be my appeal to you to introduce moderators to the group, to the audience. We have 3 moderators today, sir.
I don't have their details, so would you please go ahead
Yeah,
and
I
give
have
that
put
to
it
them?
on screen. It is displayed on the screen, sir.
Oh, of course, Dr. V.S. Ramchandra is currently the visiting consultant with the Apollo Hospital, Continental Hospitals in Narayan, Hridayalaya. He is a full-time work with a holistic group of hospitals. He has previously worked as a trainer at Apollo Hospitals, Dhaka, interventional cardiologist and arrhythmia specialist with Global Hospital Group, professional head of the Department of Cardiology at Kasturba Medical College Hospital, Manipal. Dr. Ramchandra has been trained in interventional cardiology in the University of Alabama, Birmingham, and I visited that center, and I think it's a great center. Anyone who's had a training there would come back so much enriched with the knowledge that I think he will usually make a headway in his own field. Pediatric electrophysiology in Children's Hospital. So it's a variety of training. I think it's multifaceted and very talented doctor offering his services to the various centers that he's visiting. He has number of publications to his credit, and he has contributed chapters in the textbooks of cardiology. Dr. V. Ramchandran is a well-known figure in our country. But not only that, but today when we will be listening to him at one point of time or discussing the various aspects, he's currently in Hyderabad, and it's my pleasure to have him on our board. Dr. Ajay Mahajan. I know him so very closely because he had been my student and he worked with me for several years at Sion Medical College. And he is a very quiet man, but a very, very, very talented man. He speaks very little, a man of few words, but a lot of action. So you, as you see here, a number of publications, and he has been a teacher at the university level from Sion Medical College. He has been examiner for a postgraduate students, both in DM and DNB, and he's worked as a proctor for cardiac structural and complex coronary intervention cases at the various countries, including Yemen, Mongolia, and Uzbekistan. Ajay, I'm meeting you after a long time, and it's my pleasure to have you with me to help me to conduct this seminar. Thank you, Ajay. And finally, Dr. Sanjay Bhatt. He is an academician trained in trained many cardiologists in the state of Karnataka. He has undergone specialized training in complex coronary interventions, IVAS, FFR, OCT, and you name it. Structural heart disease and peripheral vascular interventions at Cleveland Clinic. He has achieved a special training, and he also worked Mount Sinai Hospital. I presume he might be working at that point of time with Dr. Samin Sharma, who is one of us actually, and he's currently performing many complex coronary interventions and device implantations for congenital heart diseases like atrial septal defect, ventricular septal defect, and patent ductus arteriosus. Dr. Bhatt has contributed so many publications in reputed national and international journals. Welcome, Dr. Sanjay Bhatt.
So thank you. Now we will commence with the speakers. So here we have the first speaker. Request you to introduce and welcome him, sir.
Dr. Gokhale, I've shared platform a couple of times in Hyderabad, and we had a short period of time where we were sitting next to each other and we were conversing informally and generally. And I came to know about Dr. Gokhale a lot, that he's a very talented, very bold, very courageous surgeon, and he would undertake anything and everything which might have been even refused by the other surgeons, because he's confident, he's capable, and he's courageous. Dr. Gokhale has done more than 16,000 open heart surgeries, including 41 heart transplants, and also done 5 lung transplants, both single and double. And this speaks a lot about him, that he has set up not only a center, but he has set up a team which supports him to achieve such brilliant results in the cases that he has already handled. And in the world, he is the first surgeon to transport heart in a dedicated metro train and do successful heart transplantation in February 2021. This has gone in the history, and his contribution in the field of cardiac surgery, including heart and lung transplantation, has made him well known in not only national but international societies. Welcome, Dr. Gokhale.
Thank you, sir.
Pleasure for me.
So you can share your screen. I'm stopping the screen sharing, sir.
Yeah. I hope you are able to see my screen now.
It's visible, sir.
Yeah. Good morning, Dr. Mehta, dear colleagues and participants, and to Relisys. I thank you all for giving me this opportunity to be here with you and share some of the surgeons' perspectives on valvular diseases. It is a rare opportunity that a cardiac surgeon gets to speak before cardiologists. This is one of the areas where these transcatheter things are coming after surgery. And surgery remains to be the golden standard against which They look at the non-inferiority or superiority of the various things. That's how I ended up here. And I thank you, Ravi, for making me part of this. And I'm glad to know about these bicaval valves. As Dr. Mehta said, there are a group of patients, very high-risk patients, where we find it very difficult and such a novel idea. And let us see what we got from Miss Katharina. Now, see, valvular heart disease continues to be a main problem in India. Today, approximately about 2.25 lakhs of cardiac surgeries are being done. In India, about 1.3 bypasses and about 40,000 valve replacements, remaining pediatric and other things. And that's how almost about 20 to 25% of work is valve patients. Initially, it used to be actually like about 75, 80. But then in our country, the rheumatic heart disease has come down dramatically. So now the degenerative as well as the congenital, those things are taking a little higher step, even though rheumatic still contributes about 1/3 of the valve problems, what we are seeing. And the first intervention actually for valve was done using a surgeon's hand in the mitral stenosis, as we all know. And today, for doing valve replacement, we have different approaches. They do a open heart surgery, regular through sternotomy or minimal access. Now what we are going to listen is a transcatheter replacements. Now this transcatheter heart valve replacement, of course, has got a special place, which you will see in the next few things. Overall, surgical treatment of valvular disease still remains to be a best option for many as of now. For example, many of the patients in India are younger patients who require valve replacements, and often mechanical valves need to be used. And again, cost is a big factor, especially in a country like this, wherein we have different types of people, and about 70% of the people are still cannot afford. They do not have insurance. You know, this is one of the very few countries where people have to pay from their pockets. Our governments are working on making insurance for the common man, but still not great yet. You know, it's always pertinent to talk about the first heart surgery from where we have come far off today, more than a century back. In 1893, the first successful heart surgery was done by Dr. Williams for a stab injury of chest, wherein he repaired internal thoracic vessels, then repaired a pericardial injury. Fortunately, there was no heart injury, but that has opened doors for possibility of surgery on the heart. Now, a real open heart surgery started from 1953 when Dr. Gibbon did the first atrial septal defect closure using this device. And after that, cardiac surgery has grown in a big way. In India, the credit goes for the first open heart surgery to Dr. Girinath, Professor Girinath, who closed the ASD and VSD at CMC Vellore in 1962. So CMC happens to be the place where the first open heart was done, and I was fortunate to be a trainee from that center. Now, coming to the valve replacement, it is in 1962 that Dr. Alfred Gunning did a human valve replacement using a freeze-dried valves from donated corpuses. A lot of work has been done. But as of now, looking briefly at the surgical aspects for the valves, you know, at least about 5 to 10% of our patients require combined procedures like multiple grafts as valves. Still, surgery remains gold standard for it. And at least 20-25% of our patients require multiple valve procedures like mitral aortic, mitral tricuspid. So combination of these procedures for which still surgery remains to be the gold standard as of now. Now it is something which has been offered for people from newborn to octogenarians. For decades, surgery has provided great relief to like millions of valve patients from newborn to the old age. Of course, most of them with great results. Today, the results are something like about 95% success in most of the situations, at least, if not more. Of course, there are situations where the results can be a little suboptimal, but still, so far, I don't think any other procedure has given relief to the valve patients as much as surgery. And not just the age, to different pathologies. We don't restrict ourselves to it is a bicuspid valve or tricuspid valve, it is a rheumatic, whether it is a degenerative, either it is a unicuspid, tricuspid, monocuspid. So congenital, degenerative, rheumatic, infective, for various types of pathologies, surgery remains to be a single stop to most of the people as of now. And mitral repair is a big story, as you all know. In degenerative disease, about 75% of the case can be repaired. Even rheumatic, some percentage can be repaired. And the results of repair have been excellent in most of these patients, doing well for 10, 20, 30 years. And various procedures have been described in detail with a long track record, like commissurotomy, leaflet thinning, papillary muscle splitting, edge-to-edge repair, caudal replacement, secondary caudal resection. You name a number, caudal transfer. There are so many procedures have been described in detail to help these patients get back to near normal life. And as Dr. Mehta said at the beginning, Alan Carpenter, he described mitral valve pathology and mitral incompetency classified. That remains a gold standard. Whatever types of procedures you want to do, whether surgical or percutaneous, great descriptions have been done by great surgeons in this regard. Now we can give different types of valves depending on the need. If someone a child or someone has infective endocarditis, we can give an autograft. Or someone who is about 60, 65 years of age, we can offer tissue valves, that's the porcine valves or pericardial valves, depending on the situation. And someone who is young, who has a life of about 40, 50 years of span, we can offer mechanical valves. And there are certain situations where homograph valves can also be used. So it is not that there is one type. We have different type of valves to offer different patients depending on the need. These valves had a huge track record. See, from the Hufflagel valve from 1962 onwards, many valves, Starr-Edward valve, Bioxley valve, there's so many valves that have come. Now St. Jude, Carbomedics, they all have a huge track record. And we know what is happening with those valves. They have evolved over a course of time to get the best results as of now. Same thing happened with the tissue valves. You know, they were initially only a simple pig valves, but there are a lot of modifications, decalcification, and they have come to an extent today, the transcatheter valves are actually evolution over the existing tissue valves that are used surgically. There's so many different type of valves are having a huge record over the long term. And the surgery is not just for the first time, and we can do for redo as well as a redo surgery, redo surgeries. Depending on the situation, many of these patients can be salvaged by surgery with a proper preoperative preparation, not restricted. And it fits to all the people's pockets, not someone who is rich. For example, these transcatheter valves, as of now, are very costly. And many of the people from outside the country would be shocked pleasantly to know that we can do a valve replacement for a government patient for $1,600. Barely 1.25 lakhs. We have a valve that fits into that. And we also have valves which cost huge money. And we can, if the patient can afford, we can charge them up to $10,000. So this is something which probably not many countries have got that comfort, but in this country we can do for $600 onwards. So we can take care of the many patients. And there's a huge track record. We know the follow-up of these patients for decades. There are valves that are followed for 20 years, 30 years, even more than that, whether mechanical or tissue valves. We know exactly to tell the patient how long it is likely to last. In general, this track record is existing in these valve patients. And we have learned from the problems we have faced. There are many problems we have faced: infective endocarditis, thrombosis of the valve, thromboembolic disorders, many of these situations, paravalvular leaks. Today, most of the cases, we are able to solve the issues with a reasonable comfort. Yes, of course, there are many problems. As a surgeon, I agree. Yes, we heard our problems from the patients and we are sensitive to their issues. So what we have done, we have come with the minimal access surgery. You can see in the center, there's a sternotomy. Now on the top left, you can see a partial sternotomy for mitral and aortic. Then this is a mitral valve. Now you see in the bottom right, this is a minimal access surgery. Patient underwent a mitral valve replacement through this incision. So making incision smaller, less pain, faster recovery. And even the robotics have been entering into this field, especially the mitral valve. There are a few surgeons who are doing aortic valve, and there are many surgeons who are doing tricuspid valves, making patients pain less and less, incisions less and less, recovery faster. Not only that, to make the surgery faster in these, now we got advancements in the valves. For example, sutureless valve, Purcell valve, you can put it in 2 minutes. Actually, the ischemic time is much less. And we have got Inspirus valve. Valves like this, excuse me for the spelling mistake, valves which are likely to last longer than 15 years, 20 years from what they say because of advanced treatments. So of course, we still have problems. We know, understand, we are not yet able to meet certain demands. For example, we still have to give anesthesia and use heart-lung machine. And with their consequence, patients have cerebroembolic disorders. They have renal issues. Some of the patients have bleeding disorders. Yes, we are still suboptimal, I agree. And we have a group of patients, very high-risk patients. For example, as Dr. Mehta said, these are tricuspid patients, redo patients, the severe TR, a difficult problem with the cardiac cirrhosis. And we have patients with a severe LV dysfunction of ejection fraction of 10% and aortic stenosis, and people who are about 80, 85 years, the multiple problems wherein surgery definitely carries higher risk, where we need advanced ones like transcatheter. And we of course have the customers who want less invasive solutions. However less invasive we can never become like a small poke in the groin. That's for sure. We need to make a little bigger incisions. And there is no ideal valve process still. Yes, whatever advancement that have happened, we are far from something like a homograft. And one of the most important things we have to learn and practice, especially in this country, is a heart valve team for better decisions. What is good for the patient, instead of we doing what we know, what is available with us. I think this one area in this country, we surgeons and cardiologists need to come together, form a heart valve team and choose. It is no more a simple operation to change a valve or treat a valve patient. We understand innovation is a never-ending search for better solutions, and we have to work on these things. As part of this, of course, we are part of the transcatheter solutions in the cath lab along with the better halves. And we have to remember, this is the last slide, from whatever we say, end of the day, this is a beautiful quote by Sir Robert Hutchinson, which will remain as long as world is there with us. We have to remember, from inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of disease more grievous than the endurance of the same. Good Lord, deliver us. So with this, I thank Relisys people for bringing me into this group, and I thank all the audience. Thank you, sir.
Thank you very much. We have back-to-back talks, and I think we have 12 minutes of question-answer time allotted to us at the end of all the presentation. So without wasting any time, I'm just now going to invite Dr. Maulik Parekh? No, Dr. Anoop Agarwal is going to talk now.
Yeah. Yes, sir.
Anoop? Okay. So that Dr. Anoop Agarwal has pursued his residency and fellowship in cardiovascular disease from Loyola Marywood, Illinois, the place which was not very far from where I was trained, and it's a great center. Dr. Anoop has initiated a travel program at Care Hospital across 7 branches in Hyderabad and beyond, and has the record of performing highest number of tower cases in the twin states region, that is Andhra Pradesh and Telangana. Congratulations. I think that's a remarkable achievement. This will inspire a lot of people to take the advantage of this simple treatment, TAVR, and I think it's a way different from the surgical replacement. He is a national proctor for TAVR, percutaneous closure devices, and also coronary interventions. Transcatheter, aortic valve, and mitral valve interventions are his specialty and expertise. Alcohol septal ablation for hypertrophic cardiomyopathy, left atrial appendage closure, so on and so forth. The list is big. He has contributed various papers in reputed national and international journals. And Anoop, I have great pleasure in inviting you. Please share the screen and start your talk.
Thank you, Dr. Mehta. It's a pleasure to be here. Thank you, Ravi and Team Relisys for having me here. The topic that is given to me is a little bit more of didactic rather than a discussion. So I'm just going to go quickly through it. And if there is any questions or anything, then I can pause, or maybe we can discuss later on. So this is more like a textbook didactic than anything else. So role of diagnostics in transcatheter valve therapies. And before we talk about diagnostics, we have to understand what kind of transcatheter valve therapies we are talking about. And if you look at in the current context, there are many. TAVR has been brought up, transcatheter mitral valve replacement has been brought up. pulmonary valve replacement is pretty much in prime time now, with at least 2 valves, if not 3, available in India, and Harmony valve recently being FDA approved. The TricValve that has been brought up in today's discussion, which is the hot topic currently. And then in terms of valve repair, there is H2H mitral valve repair, and then TriClip, which has been done for tricuspid regurgitation as well. So as Dr. Eugene Braulwald was said, that there had never been a better time or more exciting time to be an interventional cardiologist than what it is right now. And that is probably what we're dealing with. And for all these minimal invasive procedures, preparation is the most important. It's the key to procedural success. And that is where the role of diagnostics come into play. So what essentially we are trying to achieve with diagnostics, we want to establish disease. Of course, we want to make sure that there is a proper cardiac ailment there for which we have got therapy option. Then we also want to establish clinical indication. Merely presence of disease does not indicate that we need to fix that. So we need to make sure we select the proper patient who has got proper clinical indication. Then the diagnostics are also aimed to look at other comorbidities. What are the cautions? What are the contraindications for the particular treatment that we are trying to plan for a patient? And then pre-procedural planning, which is purely mechanical. You are trying to make sure that you are able to do that. You basically in minimal invasive, we are working from a remote location. So we better make sure that every single thing is pre-planned. There are no surprises in the cath lab or the hybrid room that we are working with. And then post-procedure follow-up and troubleshooting in terms of, did our procedure do what it was supposed to do? So the role of diagnostic encompasses all of this, and I don't think it would be fair for me to go in detail for each of them in a short frame of time. So I have picked up few key aspects that we should talk about, and then maybe later on in the discussion we can talk. So when we talk about diagnostics, the very first thing that comes is the 5 pearls of clinical medicine. My medicine program director, he used to say, these 5 pearls are like 5 fingers of your wrist of your hand that you have to follow in every single patient. And that is history, physical, ECG, chest x-ray, and basic labs. And these 5 things, every patient which we see, whom we see, should undergo. They give you more, these 5 things give you far more information than anything else. And then the additional investigations. What I have colored in green are the tests that every patient undergoes whom we are being considering for transcatheter valve therapy. Those are echocardiogram and then cardiac CT. And then there are some of the optional investigations which are required based upon individual patient parameters. So here's an example of a pre-operative ECG or an pre-workup ECG. And if you look at it, this is typical normal sinus rhythm. It has got a right bundle branch block, slightly wider QRS. The point to note here is that there is a prolonged PR interval and there is a right bundle disease. This kind of ECG, if is in a patient with severe aortic stenosis, then going for TAVR carries a higher risk for pacemaker implantation as compared to patient with normal conduction system. So preoperative ECG in valvular therapies or in structural heart therapies is important for us to predict what is going to happen in the future and how we can risk mitigate it. So if this is the patient I would be doing TAVR on, I would try to place the valve as high as possible and try not to oversize the valve that much so that I impede on the induction, on the conduction system the least, and I prevent a pacemaker implantation on this patient. So these are some of the roles that these diagnostics play. A basic chest X-ray can also help us. In this picture, in this slide where you can see there is a PA projection and a lateral projection. In the PA projection, you can see there is a prominent aortic knuckle, which is calcified. And on the lateral projection, you can clearly see how the entirety of aorta is calcified. These are porcelain aortas, which give you trouble during open heart surgery. And also during your minimal invasive procedure, you have to be very, very careful that you do not scrape this part of the aorta, which is associated with higher risk of stroke, as well as, God forbid, dissection. So these things require a lot of planning. The other important things of looking at chest X-ray are these 2 images that I'm showing. In image number 1, you see there is a solitary lung nodule in the right lower zone of this patient. This X-ray, even if it is done for a cardiac workup, should not be missed. These lesions should not be missed because it changes how we are going to approach these particular patients. In the second X-ray, you can see it's clearly emphysematous lung. And while we know most of the cardiac patients, they do present to us with the breathing difficulty, when we have an X-ray that looks like this, we have to make sure that we are correlating symptom with correct diagnosis. It's possible in this patient, the shortness of breath is more related with emphysema rather than with a valvular disease. The basic laboratory parameters, while there are many, I have brought just a few which is relevant for our attention. So hemoglobin less than 13 is a parameter that needs to be included in the frailty assessment. Hemoglobin less than 8 interferes with our echocardiographic assessment of valve gradients and regurgitation. So if a patient is anemic, then we have to make sure that we risk assess accordingly. Similarly, if a patient has got leukocytosis, remember, we are going to put a valve in there, and we have learned from the surgeons that one thing we have to absolutely make sure is avoid introducing infection at any cost. It needs to be a sterile environment, and we have to make sure that we don't implant a foreign body in a patient whom there is risk of infection going further. Creatinine clearance is important because our CT studies and our minimal invasive procedures, they all utilize contrast. So we have to make sure that we are not causing problem to the kidneys. Albumin of less than 3.5 is another parameter that is included in frailty assessment, and that should be a part of every person's assessment. Thyroid profile, for obvious reasons, hyperthyroid patient have a higher cardiac output, and these patients also need to be in euthyroid state before we take their echo values as true. Coagulation parameter for procedural aspect, and BNP in some of the asymptomatic patient who we want to risk stratify. CT imaging is the key to everything that we do. Remember a few things, that CT imaging requires 60 to 100 ml of IV contrast, so select the patient accordingly. It needs a breath hold, so a person with a breathing rate of 30-35 won't be able to do this. ECGs are done gated at the thorax and non-gated for the vascular, and we do various phases of analysis. And for every CT scan, 4 important reporting has to be there. There has to be cardiac measurement, a separate vascular anatomy assessment, coronary assessment, and extracardiac assessment. And I'll briefly touch upon each of those. So this is the CT cardiac measurement for TAVR. Pretty standard. You get an idea that this slide demonstrates the various measurements that we take at various cuts. We also look at whether the aortic valve is bicuspid, unicuspid, or tricuspid. What is the degree of calcification? What is its angulation? And then the coronary heights with respect to the virtual aortic annulus, because all of these are important for procedural planning. Vascular assessment is equally important. And with the CT, we have got a very, very strong tool where we can look at the aorta in its entirety and plan our procedure accordingly. We can look at the tortuosity, their dimensions, the calcification spectrum, and everything, so that there is absolutely no surprise when we are inside the cath lab. CT is also important for transcatheter mitral valve replacement. And there in this particular image where you are seeing a TMVR is being planned for a valve-in-valve procedure, we look at the internal dimensions of the bioprosthetic valve. We look at the intertrigonal distance. And very importantly, we put a virtual valve inside the existing valve. And by putting this, we get 2 things. One, we look at the aortomitral angle, because that is going to help us how the new valve is going to interact with the left ventricular outflow tract. And secondly, what is our new LVOT area? Because if the new bioprosthesis encroaches upon the left ventricular outflow tract too much, then we are going to create an iatrogenic LVOT obstruction. And that is going to be a problem for this patient going further. CT can also help us where to do a transeptal puncture when we are planning TMVR. Similar thing we do for valve-in-valve. When we are planning a TMVR for a valve-in-MAC, we do the same thing. There also we look at the overall dimension, although in these cases, because the mitral calcification is not very homogeneous and symmetric, the measurements are a little bit difficult to get. Regardless, we do get the maximum and the minimum dimension, And the same thing, we place a virtual valve of the size that we think this patient is going to fit. And again, look at a neo-LVOT. We want to make sure that the resultant area, what we expect, is higher than a certain threshold. That threshold could be 180, 200, 220. There is different school of thoughts. But it certainly should be higher than a certain threshold where we expect no LVOT gradient that is iatrogenically produced after the procedure. CT measurement is crucial for transcatheter pulmonary valve replacement. Here you can see the various variations. This is a 3D virtual reconstruction imaging of CT scan, where you see that how right ventricular outflow tract obstruction and its interaction with the pulmonary artery and the branches significantly vary amongst patients, particularly when patients have already undergone one or multiple cardiac surgeries. So all these things, they need to be nicely reconstructed for a cardiologist to understand before he or she is planning for this procedure. And I repeat myself, there should be no surprises in the cath lab when we are doing this procedure. Measurements are obtained in a similar fashion that how we obtain for mitral or for aortic. This is an example of a pulmonary valve-in-valve case. There is a bioprosthetic valve at the RVOT, at the pulmonary valve area, and you can see that we take the measurements, and based upon the measurements, we select which particular valve this patient is going to fit in. This is another example where the first slide looks at the case of transcatheter pulmonary valve replacement in native RVOT. Second one that looks into the valve-in-valve, and the third one that looks into valve in a calcified conduit. And as you can see in the calcified conduit, it's not very symmetrical. Measurements become a little bit challenging, and you have to do your best work to make sure you select the proper valve size. TricValve that we are talking today, again, CT is very, very important. We are looking at the venous phase, and there we have to measure the SVC, or the superior vena cava, all the way from the confluence down to the SVC-RA junction. And the same thing we do for the IVC. Various measurements are taken, and these are certain key that tells us where all the measurements have to be taken and the length that needs to be calculated between certain points, because these things are going to help us plan what size of TricValve we are going to use, and first of all, whether we can even do a procedure or not. When we are doing these kind of CT scan, we have to get cross-sectional dimensions of the superior vena cava and the inferior vena cava. Here's an example where you see that the cross-sectional measurements are taken at the SVC confluence level, at the pulmonary artery, at the top of it, middle of it, and below the pulmonary artery level, and then measurement at the SVC and RA junction. Similarly, the measurements are taken for the IVC as well. Once we have those measurements, we are able to select which size of valve. There are two sizes available. So these measurements, they help us identify the candidacy of a patient, and once the candidacy is confirmed, what size of the valve we are going to use, so that we minimize any paravalvular leak either at the SVC level or at the IVC level. So these are the measurement details that we choose, that we take to choose which size of valve we are going to use. Now, CT scan is not just for the cardiac workup. As I said, extracardiac is equally important. This is an example of a patient, elderly lady, who is being considered for transcatheter valve therapy. And you can see the endometrium is significantly thickened with about 15 to 16 millimeters thick. We know that at her age, any endometrium which is more than about 7-8 millimeters, there is increased incidence of endometrial cancer. So this patient is an incidental finding, but an important one, and needs to be evaluated. Here is another example of a patient who is being evaluated for a transcatheter valve therapy. You see there is a solitary lung nodule on a TAVR CT protocol, which is about 16-17 millimeters. This is again puts at a higher risk of higher possibility of lung cancer, and needs to be evaluated as we are planning TAVR procedure in these cases. So to summarize, diagnostics in transcatheter valvular therapy encompasses a multimodality approach, and it cannot just be one particular investigation. All these have to come together to give us a virtual picture of what we are dealing with. And other than routine assessment, the critical investigation that we use is a CT scan. And we should be able to milk the CT scan as much as possible. And so that we don't miss anything, we should divide up our CT reading in these 4 different subsets that I mentioned earlier. One is your cardiac sizing for valve selection, coronary assessment, vascular assessment, and extracardiac finding. So I tell in every TAVR program where I'm heading, I tell them that make sure you generate 4 reports for every CT scan that you do. They need to be separate. They need to be all individually vetted by individual experts. Every operator should know how to process the raw CT images and make its own relevant observations and then match it with the data that is provided to him or her, so that if there is any discrepancy that can be resolved. Include an imaging expert in your team, your CT expert, echo expert, TE expert. That will just make life far more easier and far more safer. So that was overall my take on how the diagnostics and transcatheter therapy work. If there is any questions, maybe we can put in discussion later on. Thank you. Thank you, Dr. Mehta, and thank you, Relisys, for having me here.
Thank you, Dr. Anoop. So,
Sorry, I was on mute. Ravi, can you hear me now?
yes, you are audible,
Yeah.
sir.
I just wanted to profusely thank Dr. Anoop Agarwal. He has summarized the importance of the diagnostics before you implement therapy. Every step is very important and should be accurate. Thank you, Anoop, emphasizing that. We'll discuss in discussion over time. Dr. Katharina Kiss, who is a specialist consultant in internal medicine and cardiology, and graduated from the Medical University of Vienna, Austria, the beautiful country and the beautiful city, which I would like to visit again and again and again and again. And then one more reason is that it will give me to interact with Dr. Katharina Kiss also. And she has been in the research in the field of interventional cardiology, primarily focusing on the development of minimally invasive heart valves. And she co-founded the company PNF Products Features GmbH, which researches, develops, and manufactures percutaneous heart valves. There's a vivid remembrance of one patient in whom we did the TricValve, and that patient's life is completely changed. A young man of 30, 35, and the man who was literally homebound or on a hospital bed has been gallivanting all over the city now. This, I think, is the change that the valve treatment has made in his life. And Dr. Katharina's work in the various foundations and federations is worth mentioning. She received the title of Honorable Professor of Medicine from the University of Astana, Kazakhstan. And it is pleasure that we have Dr. Katharina Kiss with us. And let me, like you all, I am also keen to listen to her talk. Dr. Katharina, please share the screen.
Thank you very much. So I hope you can see my screen. Thank you very much for the very kind introduction. And it's a great pleasure, and I have to congratulate Relisys on establishing this fantastic series of webinars, which is also a joy from my side, and it's highly interesting to hear all the different opinions and experiences. And I'm very fond of India. I'm very sorry that I cannot travel at the moment in person, but I'm looking very much forward to be there soon again. And I couldn't agree more with the 2 previous speakers. First, I think the formation of the heart team is essential. We have to put our decisions, our experience, and our spirits together for the sake of the patient. And I couldn't agree more with Dr. Agarwal for the importance of diagnostics, because the quality of preparation determines the result of the procedure. I think everybody in this audience is aware that with the tricuspid valve, we are not treating a valve. We are treating a pathology of the right ventricle. The valve itself has a very difficult structure. It's multiplanar. We do have a free wall dilatation, so the tricuspid annulus tends to become huge in tricuspid regurgitation, and we have a lot of important cardiac structures in the proximity of the valve, which we have to take into consideration when planning our treatment. Why is it important to treat tricuspid regurgitation? For a long time, it was named the forgotten valve. Patients were treated with diuretics, but it was not considered to be of such importance. Sorry, that was the, let me start again. So why is it important to treat TR? Because I think we have understood over the last years that in the presence of TR, prognosis is severely impaired. And this has been shown in several clinical trials. And I think it is very important to understand that even the presence of moderate TR can already change the life of our patients significantly. This is even more true if we have a combination of left-sided valve disease and left ventricular systolic dysfunction. And we can also appreciate that the combination of left-sided valve disease and severe tricuspid regurgitation has a mortality of up to 30% per year, which I think is a huge burden that we have to take off our patient. And we know that heart failure and atrial fibrillation are dramatically increased in this patient cohort. So I think this is a very important slide because it summarizes our dilemma. We first have to take into consideration not only demographics, clinical symptoms, comorbidities, cardiac disease, and surgical characteristics, but of course, when planning our transcatheter procedure, we also have to take into consideration the severity of TR, the annulus size, tricuspid valve morphology, right ventricular remodeling, and pulmonary vascular resistance. And all of these facts have to lead to the heart team decision-making because we want to treat our patient at a point where recovery is still likely. Many of the patients with long-standing TR might have passed this point or might be very close to a point of no return where we cannot help them with any technology. So I would like to cover with some slides the variety of procedures that are out there, and the majority of them, of course, mimic surgical approach. I think most prominent are the cooptation devices, such as the TriClip and the Pascal device. This is why I would like to come back to that later. For valve replacement, many attempts have been made, many devices have disappeared again. So I think for the time being, the TricValve is the device with currently the largest experience in patients. If we look at this algorithm for transcatheter tricuspid valve repair, we are mainly talking about secondary disease, of course. And if we look at phase 1, then we only have a mild dilatation of the tricuspid annulus. We might address this with several devices, but most of the time, those patients are also not symptomatic. Of course, when we move to phase 2, we already have patients with a moderate tricuspid annulus dilatation, with a tethering of the leaflets. Cooptation is getting larger, and we could think about a combined approach of annuloplasty or cooptation devices, but of course also valve replacement. In this place, heterotopic valve replacement is an option. If we move to phase 3, patients that we see very commonly in our clinical practice, then we see severe tricuspid annulus dilatation and tethering. We see preserved mild, moderate right ventricular function. And these are the patients that we consider suitable for the technology. And then, of course, we have end-stage chronic heart failure where we might consider CAVI, so the TricValve, as a compassionate use. So really patients with no other treatment option where we would like to offer a life-saving treatment because we have no other option. And I would just like to go through some data that have been presented at the recent EuroPCR. And this is a very interesting registry or analysis from the TricValve registry. This includes more than 400 patients that have been treated with various devices for tricuspid disease. And I think the approach is very interesting that the investigators tried to understand which patients will benefit from tricuspid procedures. So here they divided it into good responders, responders and not responders, trying to understand which patient would improve with regard to Neuhaus stage, to peripheral edema and ascites. And what was shown is that the majority of the patients that had a good, reduction of tricuspid regurgitation of more than 2 or 2 were obviously the good responders. But then also patients that had more symptoms at inclusion, but no ascites, were determined to have a better prognosis. And I think it's interesting to see that also left ventricular ejection fraction, patients with an impaired left ventricular ejection fraction tended to improve more than actually the patients where we would expect improvement. And the location of the jet was also important. So it is important that we treat patients with symptoms. We might reconsider our decision if the patient is already with ascites. If we look at the results of the Triluminate trial, and these were the 2-year outcomes that were presented, because I think in our daily practice at the moment, cooptation devices might be the most used alternative or other device that we have to consider when deciding. And here we can see that this is just a small number, 48 patients that have reached this 2-year endpoint by now, but we can see that the TR grade was significantly reduced. But what we also have to take into consideration that the patient cohort was not so ill. If we look at the Neuhaus stage, then we have the majority of the patients, 2/3 in Neuhaus stage 3, but 1/3 in Neuhaus stage 2, and only very few patients in Neuhaus stage 3. And this could be improved by putting like almost 2/3 of the patient, more than 2/3 of the patient in Neuhaus stage 2, and this could be remained over the years. But what I would like to point out is if we look at the baseline characteristics, then we can see these patients are of typical age. The majority of the patients is an AFib, and we do have the majority of the patients with prior valve implantation or a repair. This is very important because this is the main patient cohort that I think we will be addressing. Patients that underwent prior valve intervention in the previous years and now come back with severe tricuspid regurgitation, where we know that their life expectancy and their prognosis is severely impaired. What I would like to point out that treating the tricuspid valve is not easy, and I think all our colleagues that do imaging are aware of that. It's very difficult to visualize the anatomy appropriately. And here we can see that in the majority of the patient, 2 or 3 clips were needed. So I would like to concentrate on some of the exclusion criteria because I think it's important to understand where the limitations of each technology are. So patients were excluded with a systolic and SPAP more than 70, which I think is reasonable because we don't want to get patients with primary pulmonary hypertension. But any prior tricuspid valve procedure that would interfere with the placement of the TriClip was excluded. Same as pacemaker or ICD leads that would prevent appropriate placement. The tricuspid valve leaflet anatomy, which may preclude clip implantation or proper clip positioning. Evidence of calcification, presence of severe cooptation defect, severe leaflet defects, Epstein anomaly, and of course tricuspid valve anatomy that is not evaluable by TTE or TEE. So a high percentage of advanced patients are left untreated. So this is why I would shortly like to introduce the TricValve as a bicarval system, and I would just like to show a short video just to make the audience understand the principle of placing 2 valves into the superior and inferior vena cava. So this is a normal functioning heart. We are all aware of the anatomy. And once we have tricuspid regurgitation, the cooptation will increase and we will have a largening of the right ventricle and especially also of the right atrium. I think it's important to see that the majority of our patients are in AFib due to this pressure or volume overload in the right atrium. So this is how the two valves are placed in the superior and inferior vena cava in order to prevent backflow into the cavas. They are both placed via the transfemoral vein, so it's a very low risk, minimal invasive procedure. This has already been introduced, the two valves with dedicated design, the one with the belly for the superior vena cava with a longer skirt that prevents paravalvular leakage, and the crown that is dedicated to be placed into the confluence of the vena brachiocephalica, and then the inferior vena cava valve, which is with a short sleeve in order to allow intrahepatic vein inflow. Very importantly, the valves come with dry tissue technology, so that means they are pre-mounted because I personally think it's a matter of safety of the risk of contamination is significantly decreased, and of course the handling of the valves is much easier. This has of course undergone all the necessary testing. It has also been shown that the calcium content in the dry tissue is significantly lower, and this is how a close-up after 200 million cycles looks of the dry pericardium. The valves come in different sizes as of their self-expandable nature. It is possible to cover the majority of anatomies with the existing sizes. The measurements have already been very nicely shown by the previous speaker, and these are just some of the screening criteria, which I think also the following speaker will elucidate more, but we try to see patients that are symptomatic, that still have a 6-minute walk test that makes them a good candidate, but of course this is to the investigator's distinction. We want to see the V-wave in the IVC and SVC, especially in the V-wave higher than 20, maybe we can go down to 50 millimeters of mercury depending on the patient's condition. TAPSI more than 14. Also here, I think it's important to consider vascular resistance and right ventricular function. And in a clinical trial, an SPAP of less than 65 was recommended. I would like to take you shortly through the clinical trial program, and there is a special access program, so-called compassionate use, which has been allowed all over the world due to the lack of alternatives. Then the first in-man study was performed in Lithuania, now entering the third year or finishing the second year of patient follow-up, and the Tricus Euro study, which was conducted in Austria and Spain. And I would just like to present some results very shortly on behalf of the Tricus investigators. So if we look at the patient cohort comparable to the one we saw before, I just want to point out that again here, also more than half of the patients had prior valve intervention. And we can see that from both clinical trials, in hospital mortality and number of adverse events show that it's an extremely safe technology. There was one device embolization in the early trial due to a low placement, but I think this can be avoided by proper planning. It's important to mention that patients can also be done in local anesthesia under sedation only with the help of transthoracic echo, as echo is only needed as a help for the placement of the inferior vena cava valve. If we look at the functional outcomes, then we see we could reach a significant reduction of the Neuhauser stage in this very advanced patient cohort. The 6-minute walk test as well as the Kansas questionnaire could be significantly improved. And we have to remember that this was all taking place during the COVID pandemic. So there was a very strict stay-home order for the patients in Austria and especially in Spain. And we all know how this impacts on our elderly patients. A very important question is what happens to the right heart, to the right atrium and the right ventricle. And there it's very important to see that there is a decrease of right ventricular parameters due to remodeling. And this is a very nice example of one patient that had almost 50% reduction of the right ventricular volumes at the 6-month follow-up. So what we have seen so far also is that in the initial phase, there might be a short rise in right atrial pressure, but we can see that there is a significant decrease in the Doppler backflow in the hepatic veins, which I think is the easiest parameter to follow up on those patients. And immediately after implantation, IVC valve drops significantly. So in conclusion, the technology avoids backflow and reduces congestion. It promotes right ventricular remodeling and therefore improves symptoms and hopefully also impacts on mortality. But if we look at the early data now from the Lithuanian trial, we have 0 device-related mortality. So I think this is a ray of hope in this very ill patient cohort. So just to put together, it's a very easy procedure with a very fast learning curve. We are very confident that after 2 to 3 procedures, you will be very well doing the procedure. It's a fast procedure, which I think is important in this very ill patient cohort. With appropriate planning, you can reach a very high procedural success rates. The valves are already pre-mounted, so it makes it much easier, and it's a venous access. It's important that the valve can be recaptured up to 80% deployment, 80 to 90, and it doesn't disturb any right annular structures. And this is also, we are preparing a clinical trial with the Cleveland Clinic at the moment, and they're very excited because Cleveland Clinic thinks that it's a unique device because it does not block any future treatments, because you can still go transeptal, you can go through the inferior vena cava valve. And I think this is important as we are only in the beginning of a long journey. So in conclusion, I think it's a new, promising and less invasive concept, and successful and uneventful initial experience shows the feasibility of applying this new therapy in patients. And it was associated with a significant improvement in functional status, quality of life, and hemodynamics. And it might open a new avenue in the treatment of TR. Thank you very much for your attention.
Thank you, Dr. Katharina, for a beautiful demonstration of step-by-step approach to TricValve. And now, Ravi, do we have one
Yes,
more
sir.
speaker?
Yeah.
Right. I think he has obliged us by accepting invitation at the last minute, despite his busy schedule. And I'm very much pleased to invite him to talk on interventional, today's subject, and then that is Dr. Lluis has carried out his PhD in clinical medicine and biomedical sciences at Laval University in Quebec, Canada. And he's co-authored more than 50 research papers in peer-reviewed medical and cardiology journals. Dr. Lluis, please share your screen.
Okay, can you see my screen?
Yeah, your screen is visible, Dr. Lluis.
Okay, thank you very much. So good morning to everyone. Thank you very much for the invitation. It's a great pleasure to participate in this webinar. I'm going to present a case that we performed recently that was a really challenging case that required a combination with several devices, several transcatheter devices, but could finally be solved with a TricValve, as you will see. So this was a 77-year-old woman with prior transient ischemic attack, chronic kidney disease. From a cardiological point of view, she had a permanent atrial fibrillation and a mechanical mitral valve replacement in 2003. During follow-up, she developed severe functional tricuspid regurgitation, symptomatic, functional class 3, right heart failure. And so the case was discussed in our local heart team, and given the high surgical risk, she was considered for a transcatheter therapy. Here you can see the baseline echo, where we see a massive functional TR due to dilation of both the right atrium and right ventricle. And at the right, the transgastric view, you can nicely see that this is a complex anatomy, almost a quadricuspid valve, because the anterior leaflet is bileaflet or has two scallops, and there is a large, huge jet, regurgitation jet that affects the whole septal coaptation line, not only anterior, but also posterior. However, given that since there was no central gap, no central coaptation gap, we decided to try first an edge-to-edge repair, transcatheter edge-to-edge repair. So this is the first procedure. Here, as I said, it was a complex procedure because of the complex anatomy and because the acoustic window was the acoustic window. Sorry about that. Okay, sorry about that. So as I told, was a complex. We had a bad acoustic window, so we had to alternate transthoracic and transesophageal echo. But in the end, we got a good result with significant TR reduction from grade 4 to grade 1 to 2 at the end of the procedure. So residual mild to moderate TR. However, 2 weeks later after the procedure, we observed that there had been a partial single leaflet detachment of the posterior clip. As you can nicely see here in the transesophageal echo, in the transgastric view, the posterior clip is attached only to the septal leaflet, but the posterior leaflet is completely free. And this generated again a massive TR. So we decided to bring the patient back to the cath lab and to implant a third clip more posteriorly near the posteroseptal commissure, with some reduction of the TR, but still there was some an important TR in between the two clips, interclip. So we decided to close the gap between the two clips with a 16 millimeter vascular plug, and in the acute phase, at the end of the procedure, we got a good result. Residual TR grade 2. So this is the fluoroscopic views where we see here the detached clip just before and after implanting the third clip and the vascular plug. Unfortunately, during follow-up, what we saw is that the vascular plug was slightly more ventricular than initially placed. So, and the patient had again a significant TR. So here, at this point, we had a patient that had 3 clips in the tricuspid valve. She was still very symptomatic. And when we looked at the vast armamentarium of devices to treat TR, transcatheter devices, of course, in our patient, the only device that could be fit, that could be used, was heterotopic cavi. And indeed, she was a very good candidate for TricValve because from a hemodynamic point of view, she had a significant B wave, 20 millimeters. She had no pulmonary hypertension, a good ejection fraction, and all nearly normal TAPSI, 16, 17 millimeters. So we decided to go ahead with TricValve. These are the measures of the preprocedural workup. As Dr. Agarwal and Dr. Kiss has previously said, preprocedural workup is extremely important to avoid surprises in the procedure. So here are the measures. We knew that all measures fit within the range of the 25 millimeter superior valve, except for a borderline length in the distance between the confluence with the innominate vein and the pulmonary artery was a bit short. And in this sense, here you can see it in the green line is the distance between the confluence with the innominate vein and the pulmonary artery was a bit shorter than expected. So we knew that the implant had to be a bit higher than normally. But fortunately, the diameter of the brachiocephalic vein was large enough to accept a high implant. So this point could be safely solved quite easily. Regarding the inferior vena cava measures, all measures fit within the range of the 35 millimeters valve, except, again, for a short distance or a short landing zone between the inferior cavoatrial junction and the hepatic veins that normally has to be at least of 10 millimeters. In this patient was 6 millimeters. So we already knew that the inferior vena cava implantation, valve implantation, would be more tricky or more challenging than the superior one for three aspects. As I said, given the short landing zone that was only 6 millimeters, there were there were some concerns of device stability. But there were no concerns regarding a potential occlusion of the hepatic veins, because as you can see here, the ostia of the landing of the hepatic vein was very large, was 27 millimeters, and the skirt of the inferior valve is only 20 millimeters. So it was almost impossible or very difficult to occlude the hepatic veins. But given the short landing zone, we knew that we had to do to implant as low as possible to reduce, first of all, potential paravalvular leak, and secondly, to avoid a potential pop-up of the device into the right atrium. So the second anatomical challenge was that the inferior vena cava at the level of the junction with the right atrium had an extremely elliptical shape. And the third challenge was that there were some concerns, some issues regarding how the device would behave after implantation, given this kind of venous recess that you can see here. But we decided to go ahead with TricValve. This is the baseline anatomy, the baseline angiography, where we can see the brachycephalic vein and the denominate vein. Since this was a third procedure, complex procedure, we decided to work with fusion, CT fusion, echo fusion, that is Heart Navigator, Echo Navigator. Indeed, fusion with CT was extremely important, extremely useful to determine the exact landing zone or superior landing zone of the superior valve that was slightly above the innominate vein. Here you can see that the belly of the superior valve is already deployed, and at this point is completely sealing a potential backflow toward the superior vena cava. So we were very happy with this position, and we decided to release the superior valve. And this is the final result of the superior valve, where there is minimal protrusion into the right atrium, and there is no residual leakage. So we moved on to the inferior valve. As I previously said, given the short landing zone, the implant had to be as low as possible. Here again, CT fusion and also TEE were extremely useful to determine the landing zone. Here, as you can nicely see in the TEE, you can see that the valve is protruding no more than 10 millimeters, no more than 10 millimeters within the right atrium. So here the device looks very stable. Here you can see the angiography. We continue to deploy the valve, extremely slow deployment. Here, more than 2/3 of the valve have been already deployed. Position has not changed. We are not occluding the hepatic veins. So we were, and the valve is already functioning. So we were very happy with the position. We decided finally to release the valve with no tilting, with very stable. The device was very, very stable, and the result was excellent. And here you can see the final TEE of the after inferior valve implant. The valve had been implanted exactly in the intended landing zone, with minimal protrusion within the right atrium. There is no interaction at all with the interatrial septum, and there's a complete sealing. There's no residual leakage, as you can see here in the final angiography, where we can see that there is a complete sealing of both the superior and the inferior valves. So I think this is a very illustrative case because it demonstrates that although there are a lot of devices, several devices for treating TR, transcatheter devices for treating TR, to me, I think that CAVI or TricValve is probably the only one that can be used at any time or even as a last resort therapy, regardless of the presence of prior transcatheter leads, prior coaptation or annuloplasty devices. So this is to me the main message, and thank you very much again for the invitation.
Thank you very much, Dr. Lluis.
Thank you.
Thank you very much. The time is just about 12 p.m. and we could have, Ravi, we could have about 15 minutes of discussion. Maybe it's very interesting subject.
Yes,
and
sir.
people could be having lots of questions. a little exceeding time should not matter much, but I think an important discussion is very necessary. And this kind of galaxy of people, we would rarely be able to um, get all of them together. So let's take the best advantage of that. So Ravi, my first thing is, Dr. Gokhale, I think you definitely very nicely enlightened one more thing, and that is the current structural heart disease treatment requires the input from the cardiac surgeon, cardiologist, anesthesiologist, maybe sociologist, maybe patient's relations, and so on and so forth. The heart team concept. And there is no question that the obligations that we cardiologists have undergone from the surgeons are innumerable. In fact, we started firing guns on your shoulder, and had there been no support from surgeon, interventional cardiology would not have taken birth. So I do appreciate the surgeon's contribution in the development of interventional cardiology. That was very large-heartedness, and not only that, but they always believed that the best option is meant for patient and not for doctors. So with that, Dr. Gokhale, you heard all the speakers. Currently, what would be your approach to a structural heart disease, which is what kind of option you would prefer, like which patient should go for surgery or which patient should go for a interventional therapy, and very clearly where cardiologist and the cardiac surgeon would come to a unanimity.
Thank you, Dr. Mehta. That was very nice of you to appreciate surgeons from cardiology side. See, what's happening is for a long time, we think that we are probably have the same size pie and we are trying to share from that pie. It is not that. Today, with increasing all the options available, actually the pie size is increasing. More and one number of patients for whom we have been avoiding surgery or treatment, leaving them on medical management, and assigning them to their last few days of life. We are actually taking them. For example, this patient for whom we got this classical case presentation where someone had a severe TR and that probably wouldn't have done anything before. We got plenty of them with advanced valve diseases, either primarily or following valve replacements. We all understand following, for example, mitral valve replacement, people do develop LV dysfunction over a course of time, PAH, there is a severe TR. So we got a huge number of patients, for either redo patients or primary patients with advanced heart disease, advanced age, risk factors like renal issues. At least they contribute 20 to 25% of our patients with increasing experience. And they are the patients for whom I think we should try these, get our experience. And once they are good for bad cases, they are likely to be good for even straightforward cases. So I think over a course of time, this, like the angioplasty, percutaneous interventions have got a great role because our primary job is as practitioners, as you said, to the patient, not to the procedure, not to the company. And if we give this option to the patient and they work for 10 years, now we are putting valve in valve, as a matter of fact. So I see great future for this, but I always feel that we should work together, take a cautious approach, and then move ahead to make patients' life comfortable, make them recover faster, and make it just like angioplasty, have the procedure. I had a patient recently, severe LV dysfunction, is about 80 years, and as aortic stenosis, the patient came to me for surgery. I called my cardiologist and I said, let's do TAVR for this patient. And I was part of it. It's such a pleasure. No anesthesia. Patient got up and walked the next day and has gone home. Pedal edema subsided in a week's time. I mean, it's wonderful to see the benefits patients get out of these things in some of these patients.
Yeah, I agree totally with you. I think it's a teamwork.
Yes.
And I think, let me in that situation, I have two panelists with me, Dr. Mahajan and Dr. Sanjay Bhatt. Ajay, what are your views on this topic?
Sir, this is the very best concept to deload right ventricle, but I am having some issues, some questions. So if the patient is having a small PFO, then it is a contraindication to do this therapy. Then another question from my side is, if the RV function is too less or TAPSE is less than 13, that patient is absolute contraindication to any open heart surgery. So can we do similar case, similar procedure in these patients where RV function is too much compromised?
Well, if
Yeah.
I
Go ahead.
maybe might answer from our experience, because regarding the PFO, I think it's a very important question, because we have patients that underwent mitral clipping, for example, so they might have an iatrogene, a PFO, before the TricValve implantation. And what we normally recommend is to close it, because due to the rising pressure in the right atrium, we could experience the PFO becoming relevant. So I think in the cases where the PFO is expected to be an issue, I would rather close it before the procedure and then go for the TricValve for the cardio implantation. And the second question regarding the TAPSE, that depends, of course, very much. I mean, I think we need to evaluate right ventricular function and pulmonary resistance. In patients, of course, that had undergone prior tricuspid valve annuloplasty, anyway, we cannot rely on the TAPSE. In general, I think the right ventricle, if it's too impaired, then we might enter this point of no return. But I think this is a question that we are just starting to understand and to elaborate, because we have actually seen in our compassionate use patients that some of those where we would not have expected improvement and where it was really like a last option to offer to the patient, we could actually see significant improvement. And there are some patients with good right ventricular function where you would think that this is a perfect patient that would improve dramatically, and some of them do not. So I think the TAPSE, look, the TAPSE was taken out of the clinical trial where, of course, you want to have a homogeneous patient cohort. So we try to define the parameters in a way that we would have patients with a good prognosis and rather homogeneous. Now, of course, where the TricValve has received the CE mark and it's open for use in Europe and in many other countries in Asia, we will see how much lower we can go with the TAPSE, how much lower we can go with the V-wave, because of course we also need the V-wave responding to backflow into the cavas to have proper valve leaflet function. So some of those questions will need to be answered in the next future.
I also want to ask one question. It is very theoretical, but is SVC implantation lead to increase in some velocities in right pulmonary artery?
No, we have not seen any of that now.
Oh, thank you.
Thank you very much.
Anoop, are you with us, Anoop?
Yes, sir.
I have a couple of questions.
Sir.
You very elaborately mentioned about the investigations, diagnostics prior to implementation of therapy, because they will help you to very accurately deliver an appropriate therapy. Two questions, I think. What is the importance of membranous septum in relation to development of need for a pacemaker or conduction disturbances? And second thing, majority of the trials have excluded the bicuspid valve. And the information for the bicuspid valve has been largely from the registries only. So I want your little bit of comment on bicuspid valve. Should you face the situation of bicuspid valve and the importance of membranous septum? Would you keep that in mind? Would that information be essential or not?
So, sir, both are absolutely relevant. I think the membranous septum part, it was handled last year when the concept of Midas touch was introduced in one of the research, and the term was very catchy, that now we should be talking about this thing called Midas touch, where if you mind the membranous septum, then you will have a single digit or less than 5% pacemaker rate. And the key number that people there came up was if the membranous septum length is more than 8 millimeters, then there is less likely of you interfering with the left bundle and less likely of causing pacemaker implantation. We tried measuring membranous septum in our lab, and we ourselves were not very consistent in how we are measuring. So the both inter-observer and intra-observer variability of measuring the membranous septum was very, very significant. The way I look at it is, if I see membranous septum clearly, and if it is long enough, I don't have a cutoff myself, then I'm okay even while diving a little bit in. But if the membranous septum is short, then I try to ride it high. But I really cannot come up with a cutoff, because my own measuring of the membranous septum, I'm not confident at it. I'm not confident at whether the number that I'm getting is accurately depictive of the true length of the membranous septum as well. The other problem is which plane we are measuring. That also is very difficult, because in certain planes, it seems like membranous septum is 10 millimeters. In certain plane, it seems like it is 5-6 millimeters. So it's not in prime time, but certainly good thought that we're talking about.
Well, I'm in a process of evaluating for those patients who have a very severe kidney disease, where GFR is less than 40 or 30, where I'm really having a serious constraint of use of dye. And I'm trying to do an evaluate sensitivity and specificity of MRI-based information for accurately placing a aortic valve percutaneously. And maybe, I do not know, but we started working on it. And I think if we find that there's a good sensitivity and specificity as compared to gold standard, and that is a CT scan, then I think it will be a great help for a kidney people and a kidney disease and the aortic stenosis are not uncommonly coexisting.
Absolutely. Absolutely. I think this is very relevant. In our lab, we have a standard protocol that whenever a patient goes for a CT TAVR, we also do a MRI of the heart as a free of cost. That is not a report generated for the patient, but we are doing MRI to kind of better understand what are the myocardial dynamics, particularly the leaflet motion and whatnot, so that we overall maybe extract some data out of it and then put it in a meaningful fashion. I think MRI is going to go as one of the main therapies in the future. Definitely, there is no doubts about it.
Right, sorry.
Yeah, we do use CT for coronaries as well. So that is something that we do, so that we are able to avoid coronary angiogram in almost 25-30% of the patients. So that is another thing that we do as a part of saving contrast.
Just one or two hints about the bicuspid valve. There is no randomized study because they all have excluded bicuspid valve from randomized studies.
Yes, sir, they have. But we have got enormous data. I agree they are all registry data, but we have got enormous data now. There are reports of more than 500 case studies published using the newer generation valves, not the older generation valve, but using the newer generation valve. The results are very, very consistent. And you don't have to go too far. If you look at our home country, where 40% of the cases that we are doing are bicuspid, and our own experiences have been quite reasonable. There is limited publication from Indian data set, but whatever publication is there, the numbers look very, very compatible with the traditional numbers that you see in tricuspid valves.
I totally agree. Somehow or other, my impression is that the incidence of bicuspid valve is much higher than in the Western country. And I think we deal with bicuspid valve. I agree with you. Ours is also 42% of the cases have a bicuspid valve. And by and large, generally, if you have the general principles in place, then the bicuspid should not be considered as a very different ball game as compared to tricuspid valve. I mean, you just take a little more extra precaution, and I think a bicuspid valve can be offered in vast majority of the cases, the option of transcatheter valve replacement. Yes, Anoop. Both Dr. Katharina Kiss and Dr. Lluis, they talked about. Now, the questions were about TricValve. This question can be answered by both of you about the TricValve. We had one case of tricuspid regurgitation, but mainly resulting into the backload onto the portal vein and the cardiac cirrhosis and ascites and whatnot. And we replaced only the inferior vena cava part of the TricValve and did not touch the superior vena cava at all. And it worked. It worked extremely well, so much so that the patient is so very happy that he's able to do almost 80 to 90% of the activities that he used to do before. So, Katharina, can this not only, well, it's a shorter procedure, you avoid one more valve just by choosing to select only inferior vena cava, especially the people who have a backload onto the portal vein. Did we do right thing, or would you have a different approach or different opinion, Katharina?
Well, I think first of all, if you relieve the patient's symptoms, then for sure you did the right thing. And for example, we have some patients with carcinoid or with Chagas disease, so that have a different disease other than functional TR. But we have also tried this approach, especially young patients in Brazil that suffer a lot from Chagas disease and biventricular cardiomyopathy caused by this disease. In functional TR, we actually have a different experience. We did some patients where for one or the other reason only an inferior vena cava valve was implanted, and we saw that the pressures were redirected towards the superior circulation, and the patients were suffering from headaches, from increased jugular pressures. And in one of those patients, actually it was a patient in India, we then implanted the SVC valve in a second step through the IVC valve and relieved the patient from those symptoms. So I think we have to look, it's a new technology, and we have a lot of different diseases that all come together under the severe tricuspid regurgitation or right heart disease. So I think it's very important, as you rightly said, to understand the mechanisms and the underlying disease. So I think we will see a lot of these questions and answers.
Yes, so you are open to that.
Of course.
Yeah, wonderful, very good. Dr. Lou, you want to add anything further?
And no, I completely agree with what Dr. Kiss previously said, so completely agree.
Good. I think we had a very fruitful morning for all of us in India and the people abroad. Maybe they have an early morning now. And I, at this point of time, would very sincerely thank Relisys for organizing such a beautiful meeting this morning. And all of us have benefited tremendously. And especially the two foreign speakers, our guests, Dr. Katharina and Dr. Lluis. Please accept my sincerest thanks, because you have obliged us a lot. We know how busy and how important Sunday is, the only day of rest for you all people. And yet you have sacrificed it for our sake. And I think I have no words to thank you enough. Doctor, who's going to propose a vote of thanks? I think is Dr. Ravi. Ravi Patnaik, are you going to do that?
Sir, yeah. So it would be my colleague would do it. But before that, Dr. Katharina, there are a couple of questions. I could see you answering the questions which have come in. But there are a couple of other questions. Would it be okay if I just put it?
Yes, of course.
Yeah. So one question is, what is the thrombosis risk post-TricValve deployment?
So until now, because I think most important for this is the CT scan in follow-up, we have not seen any cases of valve leaflet thrombosis. We saw 2 small thrombi that were attached outside the stent frame in patients with a very prominent Eustachian valve. But then after adapting the anticoagulation regimen, also this could be solved. So anyway, the patients are on lifelong anticoagulation. This is in 100% of the patients that we screened until now, anticoagulation was already in place due to AFib or prior mechanical valve replacement. So I would say the risk of thrombosis is extremely low. You have to, of course, follow a proper anticoagulation regimen.
Thank you. And then there is next question from Dr. Bharat Shivdasani. Is post-TricValve subsequent pacemaker implantation possible, including biventricular?
Yeah, very important question. Yes, it is. You can go through the SVC valve or you can implant the micro. But of course, we might lose some of the function of the SVC valve, but this is to be taken into consideration. But it is possible, and I think this is one of the great advantages of this technology, that you can still place a pacemaker, you can still treat the mitral valve via the transseptal approach. So you have a lot of open possibilities for those very ill patients. And it's also, excuse me, Ravi, but it's also very important to say that, of course, pacemaker leads, be it CRT, ICD, or normal pacemaker leads, are no contraindication for the TricValve implantation, because you simply seal the pacemaker lead between the stent frame and the vessel wall. So this is very important. And I think, and just one more word, I want to congratulate Dr. Asmarats for this wonderful case, but it shows really how many toys we have out there, how many possibilities, but then how easy and straightforward you can be with the TricValve. But I think it was a wonderful case and really great to see. Thank you very much for it.
Thank you.
Thank you, Katharina.
Mehta sir, before we close, I think Dr. Sanjay Bhatt and Dr. Ramchandra, I think if they could contribute something to the discussion that has happened.
Yeah.
What will be the, the last case we had, it was a very severe tricuspid regurgitation. I think it was some sort of primary tricuspid regurgitation. And actually the TAPSE and everything was okay, but when we did a MRI, they gave a report of severe RV dysfunction. And actually a couple of other cardiologists said that we had waited too long. And the patient was also quite upset. And then actually we sent him to Gokhale and he did a wonderful job. He did a great job, the tricuspid regurgitation repair, and then he had a heart block. And of course, we put in a lead into a coronary sinus because we did not want to go through his repaired valve. But what is the point of no return for these tricuspid regurgitation patients? Because some of them who are really sick seem to do well when you close the valve with whatever technique. Maybe Dr. Katharina can answer because...
Well, I think, but what we have seen in the tricuspid patients is that if we close the valve, then many of them tend to go into cardiogenous shock. And this is obviously something that we can avoid by the TricValve, because you use the right atrium as a kind of reservoir that decreases the sudden impact of treating the tricuspid regurgitation. So obviously what we have seen that very few patients of the patients we treated, and there were a lot of patients with severe disease, very advanced patients, especially in the compassionate use program, and very few of them needed inotropic support. So I think that shows that the concept is feasible in these very ill patients. I mean, there is a reason why the surgeons are very reluctant on treating those patients, because it's not only treating the valve. We do have a problem of the right ventricle, the right atrium, and the whole system. If you look at the cavas, how much dilated they are, then we for sure have to take into consideration the whole situation of the patient. And there, the bicaval approach, the TricValve, is obviously offering a much better to digest solution for the patient, let's put it that way.
So is RV dysfunction not a contraindication for the bicaval valve?
No, but we have to understand how low we can go. Because of course, if you have very severe right ventricular dysfunction, then the question is if you have already passed this point of no return that I was mentioning earlier. But this is, I think, very normal with every technology, where you will go further and further to test the limits and to understand where your limits are. So this is a question that we will elaborate in the next days, weeks, months, and years, I guess.
I have two questions, Dr. Katharina. Post RV infarction with hepatic dysfunction, are we justified in implanting the TricValve? How early do we implant it? And what is the long-term outcomes in the RV remodeling following implantation of TricValve?
Yeah, I think the second question is very important because, of course, this is always a concern. What happens to the right atrium once you ventricleize it? Because this is what's happening if you put two valves in front of it. Because we do not change the TR itself. We only change the hemodynamics in a later course because of placing the valves and reducing congestion and backflow. So what we saw in the CT scans that were done in the clinical trial, that the right ventricle is remodeling. We have a negative remodeling of the right ventricle. Obviously due to volume, a decrease of volume overload. So this is a very positive sign. And as I said, we have up to now 2-year data of the early feasibility trial, the first in man trial. And here we could see that the patient's heart are obviously coping very well with the technology. So here we see a reduction in the right ventricular volumes. And the second question, I think, was about the TAPSI.
The post-myocardial infarction, RV infarction, patients who are having hepatic dysfunction. How early do we implant the valve?
Well, I think you can still go for it. I wouldn't say that it makes a big difference whether the right ventricular function is impaired due to hemodynamics. I would think that it's even prognostically better if the patient had myocardial infarction, but I think we have very few patients in our patient cohort with right ventricular infarction, so I think it's too early to answer that question. But if right ventricular function is slightly to moderately impaired due to whatever underlying disease, I think you are safe to move along.
What anticoagulation do you advise? Just antiplatelets or anticoagulation?
No, we need full anticoagulation, but as I already mentioned, until now, 100% of the patients that were screened were already on oral anticoagulation. In the clinical trial, we recommended vitamin K antagonists for 3 months after implantation to be on like a unified regime. Otherwise, most of the patients are on NOAC. So also in the clinical trial, the patients that do not have any mechanical valve prosthesis or not severely impaired renal function that would prevent this are all on a NOAC.
Thank you.
Very welcome.
One question from my side. Is there any cutoff from pulmonary artery pressure side? If PA pressure is more than 65, then it is a contraindication to use TricValve.
No, this is one inclusion and actually exclusion criteria taken from the clinical trial, because in the clinical trial, of course, we wanted to avoid to mix primary pulmonary hypertension and patients with severe TR. I think this is also, again, this will be a process of investigating our limits, of seeing how these patients do benefit. The cutoff was taken just for the clinical trial to have one mark to have a homogeneous patient cohort again.
Well, I might add one more thing, Ajay. Very often the pulmonary hypertension could be secondary to left heart pathology. And if that is a correctable, and if you find that by correcting the left side pathology, the pulmonary pressure comes down, by all means. But I think if it's irreversible and fixed pulmonary hypertension, then I think it would be a matter of concern.
Absolutely agreed.
Dr. Mehta, with your permission, can I just add one thought real quick?
Of course, of course.
So, you know, during my training, when I was in US, my program director used to say that knee replacements have never been shown to improve mortality. Cataract surgeries have never been shown to improve mortality. A lot of things that we do in our medicine are geared towards improving quality of life. About 3 decades ago, as a cardiology, we quote unquote shot in our own foot talking about mortality and outcomes in all of our cases. These are important metrics, there is no doubts about it. But somewhere down the line, we probably stopped paying that much attention to improved quality of life. And while we are talking about valvular therapies, this has come back, and now it is so important for us to start refocusing on how to get quality of life back for our patients, particularly our centenarians or our octogenarians and all this, who really don't care whether we add 5 years of life or not, but they really need to have a quality of life. And that is where I think structural heart interventions, particularly valvular interventions, like TricValve, for instance, or TAVR, and many of the times, like if I put a TAVR in a 85, 86-year-old person, I don't know how much they value the extra years of added life, but they certainly value the improved quality of life that we have added to them. So I think as a cardiologist, we need to start talking about, if we haven't started yet, the improved quality of life as one of the metrics whenever we evaluate any of the therapy or any of the intervention that we are offering to our patients.
I agree with you, but I would not accept it as a blanket statement for one reason. Anoop, the point is this: majority of the diseases that we are treating are aging processes. Cataract is aging process, you can't stop it. Cataract, prostatitis is an aging process. Arthritis also an aging process, so on, so on. forth, on and on and on. The point is only one. When an anticipated life expectancy is already achieved and derived, then I think the goal of improving the life expectancy becomes sometimes hypothetical and sometimes impractical. Of course, the quality of life is extremely important. I would completely agree. The day in which we will be able to change the process of aging, then I think the life expectancy improvement, and then I think the quality and quantity both will be important. Nice thought, Anoop. Very good thought. Absolutely. Okay. Yes. So Ravi, I think time for you to take.
Ravi on mute.
Yeah, sir. Before we close the session, maybe one quick question, Dr. Katharina or Dr. Louis, one of you. Do you rely on RVSM for RV function along with TAPSE?
Maybe Lluis, if you want to comment on this.
Sorry, can you repeat, please?
Do you rely on RVSM for RV function along with TAPSE?
So I relate.
Yeah.
Go ahead.
No,
sorry.
What I think it's important to understand what are the measures or what are the additional information that you take for evaluating right ventricular function beside TAPSE.
Yeah, actually, we know that TAPSE has a lot of limitations, no? Of course, especially for patients that had prior cardiac surgeries, no, where we have to evaluate other parameters, but it's probably the most simple one, and is the one that has been used in most early feasibility studies, no. So that's why we rely on TAPSE, but I think it's very important when you have especially borderline TAPSE and you're facing compassionate cases that are very symptomatic. It's very important to measure other parameters to know really the radial strength, the radial contraction, and other parameters to make sure that there is some reserve in the ventricle. No? So we rely on the TAPSE, yes, but in borderline cases, I think it's very important to evaluate other parameters, no, to make sure that you can go ahead with the procedure in those patients. I don't know if Katharina wants to add something else.
No, I think it's perfectly fine, because the more, of course, we go into those very symptomatic patients, the more parameters we will discuss. And this is also why we have a very dedicated eligibility committee in place that are very happy. They are very happy to discuss patients, because I think the more we challenge the limits, the more important it is that we come to a decision together and to look at all perspectives and that look at all important information. And this is, of course, also pulmonary resistance is important. So I think there are a lot of factors that contribute to the success of the procedure.
Thank you, Dr. Katharina. Thank you. I would request Mr. Kennedy to give vote of thanks and then conclude the program.
Good day, doctors and all those who are present. On behalf of Relisys Medical Devices, I take this opportunity to thank all of you. Our chairperson, Dr. Ashwin Mehta, for guiding us through this meeting. Our moderators, Dr. Mahajan, Dr. Ramchandran, Dr. Sanjay Bhatt. Our speakers and presenters, Dr. Gokhale, Dr. Katharina, Dr. Anoop, and Dr. Lluis, and all you delegates and attendees. Thank you for being part of this initiative of Relisys Medical Devices. We look forward to interacting with you in the near future again. Thank you all, once again, all of you, and have a good day.
Thank you.
Thank you, guys.
Thank you very much. It was an amazing experience again, as always. Thank you.
Thank you, Dr. Katharina.
Thank you very much.
Thank you, Relisys, for having me. Really appreciate it.
Thank you, sir.
Thank you. Hope to see you soon in person in India.
Yeah, I think it should
Thank
happen
you,
very
thank
soon.
you, Relisys, and thank you, everybody. My friends from abroad and my friends from India.
Thank you.
Thank you,
It was
sir.
a great pleasure.
Gokhale sir, thank you.